Good evening to everyone here. It's my pleasure to be here with you. Thanks for the invitation. So the point is that we are going to translate from healthy volunteers to patients. So in this case, I'm going to talk very briefly about the work that has been performed by 4 of us in the group of RIBEF. So let's start. As you know, there has been an epidemiological transition in Latin America. So formerly, the people used to die because of infectious diseases, which means that there is still a lot of mortality for infectious diseases. However, unfortunately, we have had an alarming increase in chronic diseases, such as diabetes, hypertension, and metabolic syndrome. However, for those diseases, we have an underlying condition, as you know, like obesity. And unfortunately, this obesity is by now a global epidemiological concern. In fact, because obesity is the underlying condition for type 2 diabetes, hypertension, and metabolic syndrome. The point is, in some countries, like in Mexico, over 70% of population is overweight and obese. And the problem is that this is translated to even children. So we have a really concern about this. In fact, in Mexico now it's called a security problem in Mexico City. In fact, this represents the high mortality rates in Latin American countries because we are asking if there is a kind of indigenous susceptibility. As you remember from a very old study on Pima Indians, maybe you remember this, Pima Indians, we are living in the borderline between United States in the southern part of United States and the northern part of Mexico. But for some reason, these Pima Indians in the United States become really obese. But it doesn't happen. Now it's happening. But before, it didn't happen in Mexican Pima population. And the point was that what's happening with those people? The point is that the exposure to high carbohydrate diets predisposed to those populations to become obese. So there is a new concept. In fact, it is not so new. A concept that is called the thrifty genes. Maybe you know a little bit about this. These thrifty genes means that there are some genetic background on indigenous populations which predispose to development obesity under the same environmental conditions. And it means, for example, in some people like Pima Indians in the desert of Sonora Desert in the north part of Mexico, the point is that the feeding was pretty scarce. So they developed some conditions and some mechanisms in order to save energy. So it means that when they face high carbohydrate diets, they become obese. So according to official survey in Mexico, I'm so sorry, it doesn't work properly. Diabetes mellitus is now the third most highly ranked cause of mortality in Mexico. Yeah, and then is ranked 6th highest in prevalence in diabetes mellitus, and it seems that by 2035 it represents over 15 million cases all around the world. Most commonly, we are using, in Mexico and many countries, we are using some hypoglycemic agents. And however, a great variability in drug disposition, glycemic response, tolerability, and the prevalence of adverse effects to these drugs have been reported. So that's why some groups are now working not only with indigenous population, but also with mestizo populations. As it was talked before for some of my colleagues, there is an admixture between Caucasian population and indigenous populations in Latin American countries. So Dr. Molina, Juan Molina Guarneros, who he didn't join us now, he is working at the National Autonomous University of Mexico, and he's doing some interesting research about diabetes in mestizo populations in one huge hospital in Mexico City. This is the Hospital Regional de Alta Especialidad de Ixtapaluca. This hospital received a lot of patients, bunch of patients, because he's exactly in the borderline with Mexico City and the state of Mexico, one of the states in Mexico City. The point is that there are a lot of poor population living all around the hospital. So they receive bunch of patients. Unfortunately, the rates of diabetes in this hospital is really high. So it was possible to perform this study. Dr. Molina performed some study to evaluate CYP2C9 and drug transporter allelic variants and their clinical implications among Mexican patients with diabetes performing or undergoing treatment with glibenclamide and metformin. Dr. Molina performed this study, which is an observational, it's not a clinical test. It was compounded by a cohort of male and female patients with diabetes undergoing medical treatment in this hospital. And then how we know that patients were Mexicans? Because, I mean, it is hard, it's hard sometimes to perform some markers, in order to know exactly the origin of the patients. So in this case, the patients were defined as Mexican when they had 3 generations of Mexican ancestry and no kinship between them. Okay. Okay, so, I'm so sorry. I'm so sorry. So the objective of this work was to describe the allele and genotype frequencies on CYP2C9 gene and drug transporters and its relationship with the variability of responses to the administration of glibenclamide and metformin among Mexican mestizos patients with diabetes mellitus. So what Dr. Molina found on his study, what he found was although genetically customized prescription remain a desirable goal to increase the chances of therapeutic success within the studied population, neither, as some of you suggested, CYP2C9 allelic variants nor dosages demonstrated a clear association with biomarker levels. In fact, all this study related to drug transporter allelic variants is undergoing. This is a study undergoing, so we don't. Dr. Molina didn't have definitive results about this. So, what the perspective of this kind of studies? The pharmacogenomic analysis in association with glycated hemoglobin monitoring may be applied to individualize dosage regimens of these drugs. So, before to move on, I want to mention that Dr. Marisol Lopez, this is regarding some of the questions before somebody asked. Dr. Marisol Lopez, she's a scientist working in the National Institute of Neurology and Neurosurgery in Mexico City. And what she found, she was evaluating some adverse effects on, I don't remember, of some drugs. And what she found was an increase in the prevalence of Stevens-Johnson syndrome. This prevalence of this disease was not exactly the same in regard to other populations. So it seems that pharmacogenetic markers are useful at least to identify some populations. It is clear that, for example, some genetic markers are useful for some populations, but are not useful for our populations in particular. So one of the main studies performed in Mexico is that performed by Dr. Julio Lara Riegos. He comes from the Autonomous University of Yucatán in the peninsula of Yucatán, in the southern part of Mexico. And what he's doing is research, diabetes research in Mayas. It is important to note that you can see the prevalence of type 2 diabetes in the indigenous population of Mexico. So you can see different indigenous populations here, Mazateca, rural population of Durango, Otomies, Pima. And if you remember, Pima was an example, Mije, Zapoteca, and Mayas. So you can see a lot of people affected by diabetes in Yucatan Peninsula. So it's very, very important to perform this kind of studies. For those who doesn't know, maybe I for sure know that most of you know exactly where it is located, Yucatan Peninsula. Yeah, you can see that Native American correspond to 81.9% of the population, and the remaining from European ancestry and African ancestry. So it is a very useful population to perform some pharmacogenetic studies because it's kind of pure, most pure of most of the populations. The remaining studies performed in some other regions, such as performed by Dr. Marta Sosa, there is a clusters of populations here from different ethnic groups. However, in the case of Mayas and Zapotecas, there are a bunch of population from the same ethnic group. So the objective of Dr. Lara Riegos, was to identify genetic risk factors to diabetes and cardiovascular risk in Mayan population. So what he found in these studies is a very active research in diabetes in Mayas. So from 2013, he found a short-term estimation and application of biological variation of small, dense, low-density lipoproteins. And then one of the main results he found is this one. I want to make notice about this, 2015. And what they found was this association of ABCA1, a transporter, and CDK2M, 2B genes, to susceptibility to diabetes type 2. This is the mutation. And the important point here is that they found that this mutation, R230C of ABCB1, this gene, is only found in the Americas. So it is not found outside Americas. So it is important to notice that these kind of studies are important to identify specific mutations, which are important not only to identify diseases, but also to identify some drug responses. Some other results that he found, he described this in 2018, this metabolic index in Mayas, association with hypercholesterolemia in patients with type 2 diabetes, and also this genetic diversity of HLA system in 3 populations. As you remember, HLA is a very diverse, it's a highly, highly diverse cluster of genes which are important not only for the development of some chronic diseases, but also for some infectious diseases. What barriers Dr. Lara Riegos found in this case, in this study? Well, he found that communication, and it's a barrier, and lack of validated instruments to analyze sociocultural variables. So as Dr. Llerena suggests, there could be social scientists involved in this kind of studies. Yeah, another very big deal is the distrust of populations in the research team. This is something we faced frequently with communities. So induction strategies are missing for the introduction of the research team in the communities. And, of course, the customs and uses in communities that are not disclosed to the research team. What they propose in order to improve this is that projects must be proposed taking into account the sociocultural context as variables to be evaluated. Patients should be treated in their native language, which we are trying to keep in mind at all times, and the treatments based on their cultural resources. And bridges must be established between the dominant culture of health services and the different cultures of the population that receive those to generate health programs with an intercultural approach. In this case, what we found is that we should take in account all the traditional medicine in order to make a synergist with the drugs that we are administrating. The conclusion of this study is that based on the scientific information that we presented, an international policy that proposed health programs with an intercultural approach should be established. Some pictures about the attention of some Mayan patients. Okay. Okay. So I want to make a little stop in this case, because in most of Latin American countries, there is a phenomenon, a very sad phenomenon, in fact, which means that most of the population are sick from diabetes, obesity, hypertension. But the problem is that women must face another problem, another big problem. This is related to increasing the mortality and morbidity in pregnant diseases. So, in fact, preeclampsia and bleeding at the postpartum stage are the main causes of mortality in women in Mexico and many other Latin American countries. In this case, as I said, preeclampsia and postpartum hemorrhage are the leading causes of mortality in women. These rates increase substantially in indigenous women. But this is, the point here is that this is because they have a lack of attention or proper attention, so it is important to study this kind of population. At the same time, as you know, the pregnant women also become sick, and become sick for many other diseases, the occurrence diseases. So it makes mandatory to use, unfortunately, we have to use some drugs in order to treat those diseases. But these drugs must be administered at the right dose, at the right gestational age, and the time of administration in order to be safe for the mother and the fetus. So in this case, we performed some research in pregnant mothers in Mexico. And the point is that we start with this project, the identification of maternal, paternal, and placental biomarkers to diagnosis and prognostic markers for preeclampsia. The objective of this was to identify these diagnosis and prognosis markers. However, the challenge with this kind of patients is to identify genetic susceptibility markers for the development of preeclampsia in women, even before pregnancy. That's a very, very important thing, because we found that most of the studies performed in pregnant women are performed after pregnancy. So it is hard to understand. For example, the women ask us very frequently, how this will be useful for me if you are taking the sample after pregnancy. So we are trying to perform a study in order to found these markers that will be useful before. However, we found some barriers, and these barriers, unfortunately, are related to health personnel at hospitals. Most of the gynecology and obstetric personnel are not interested in this kind of research. So we have to fight again and again in order to do this kind of studies. The differences in diagnostic criteria is also a barrier important, because the diagnostic criteria are different even in the same city between hospitals. So we have to face that problem. And one that is very unfortunate is the cultural aspects. and the paternal participation. Sometimes we are able to take some samples from the mother. However, they have to ask for her partner if she are allowed to become part of the project, of the experiment. And then the partner says, no, I don't want you to participate in these kind of studies, so we have to discard the sample. And it's very, very frequent that we are facing this, and this is related obviously to cultural aspects. What we found, we have some other results, but the main are those related to endothelin gene, which is a hypertensor. The main hypertensor, natural, revealed that the father has a role as a protector. And mutations in kinase gene showed association with disease development. The objective, now, in the second point, in the personalized medicine to improve drug response in pregnancy, the objective was to identify pharmacogenetic biomarkers to improve the pharmacology response during pregnancy. As you can guess, it is really, really hard to perform these kind of studies. The challenge is to improve these treatments in pregnancy with minor effects in the maternal and fetal well-being. And the barriers we have faced is the lack of interest, it's the same as in search for markers in preeclampsia, diagnostic failures, and cultural aspects, because it has an emphasis in indigenous populations. It is hard to make understand to indigenous populations the advantage that they could have in the future to this kind of results. And the main results we found is that some genetic biomarkers in drug transporters were associated to failure in the clinical response to antihypertensives in women with preeclampsia, particularly in genes like NAT2. And also, after this or through these studies, we found an evidence of placental metabolism on antihypertensives. What we found was that after the administration of the drug, some genes expressed in the placenta related to the control of blood pressure are overexpressed. So placenta is not only an organ, a passive organ, which is engaged in the transfer of nutrients and trash between mother and fetus, but also it is involved in some other issues, such as metabolism of some drugs. What we propose, return results in a culturally understandable format, the capacity to sustain collaborative research with hospitals focused on their health priorities, sensitize patients, physicians, and medical students on the importance of studies in pregnant women, uniform the diagnostic criteria and treatment guidelines through public health programs, and what regulation we have to perform to obtain, obviously, by ethics and research committees, approval, and obviously to make firm the patients with an informed consent, to explain clearly to the patients the potential health benefits, and all participants, as I said, provide written and informed consent. Now, the conclusion is that personalized medicine strategies must be developed to ensure the maternal and fetal well-being. And we are now moving to the southern part of the continent. Some studies performed by Dr. Enrique Terán. So Dr. Enrique Terán performed two kinds of studies. One of those is related to identify biomarkers for diabetes on indigenous populations, and he's also interested in the identification of markers for preeclampsia and pregnant well-being. So Dr. Terán and his group is trying to identify or perform some personalized medicine in these kind of populations, and he has a couple of problems. The problem one is preeclampsia. He's devoted to preeclampsia. As I said, is the first cause of maternal and neonatal morbidity and mortality in Ecuador. It affects approximately 20% 20% of women, and it's much more frequent in teenagers and indigenous people. As you can see, worldwide, the incidence of preeclampsia is around 8%. In Ecuador, it reached 20%, and some African countries, like I think it's Nigeria, it reached like 36%. So it is a really, really health problem. And the challenge is to develop screening methods for early detection and treatment of preeclamptic women. What barriers Dr. Terán found is the lack of interest of the health authorities for our results, limited resources. In fact, this limitation is for all kinds of studies in Latin America, and the geographical and cultural accessibility. The main result is that there is a genetic variability in Ecuadorian women with preeclampsia. There is a different response to antihypertensive drugs and several mechanisms identified as potential targets for intervention. The problem, too, is that related to obesity, overweight, and diabetes, which is affecting most of Ecuadorian people, both children and teenagers and adults and elderly. This is affecting more mestizos than indigenous subjects, and it could be related to the availability of some kind of foods. And response rates to treatment is different among them. So this reinforces the necessity of this kind of studies because the response is different between populations. The objective was to better understand the risk and protective factors for metabolic diseases and treatments. The barriers Dr. Terán in this kind of study found was that there is, again, lack of interest of the health authorities for our results, limited resources, and a hard accessibility to some places. The main results, he found also genetic variability in Ecuadorian people, different response to anti-diabetes drugs, and several mechanisms have been identified as potential targets for intervention. The conclusion of these studies is the high disease rates and differences in treatment response make Ecuadorian population different to other populations. And there should be some specific treatment guidelines which should be considered. As a general conclusion, the Latin Americans are the results of genetic admixture between indigenous and Caucasian populations together with an adverse environment made them more susceptible to some diseases. And it is important to consider specific genetic markers for these populations in order to provide more accurate diagnostic procedures and more rational therapeutic options. Thanks a lot.
I will give the floor to the president, to Professor Riegos, because we are at the end of the session. Please, if you can, I give you the responsibility to close the meeting. In that way, I will not be responsible. Lunchtime was 1:30. I think we arrived we are safe. But please, if you take the chair and you make the final dialogue, we will have lunch together. And probably all RIBEF and CIOMS group, we're small, will be in a room, so probably we will have time to discuss personally. Okay? In order to make things easy, you have the floor. You conduct the final.
Thank you. And I think we should probably try to use the time in a way that if people have still questions, I would take some questions. Yes, please.
You do a very interesting job. And I'm not doubting the importance of pharmacogenetics, but pharmacogenetics doesn't tell you what is the correct dose. So I was just wondering whether you have some cooperation on therapeutic drug monitoring, bedside therapeutic drug monitoring, or inside therapeutic drug monitoring, because the combination of pharmacogenetics and therapeutic drug monitoring may really change the world. But probably pharmacogenetic alone is not achieving what you are going to achieve.
Sure. Okay. Well, effectively, pharmacogenetic doesn't resolve by itself the problems, but we have to perform some monitoring of drugs which we are trying to do with pharmacokinetics, for example, pharmacokinetic studies, and then we are trying to translate these combined results to some future studies in which we are trying to perform some more rational administration of the drugs. In fact, as you can know for sure, there is a hospital in the United States. I don't remember exactly what is the name of this hospital, which is doing some research on leukemia in children. So they have some guidelines, specific guidelines, based on pharmacogenetic markers to administrate some drugs. However, when we try to duplicate or resample these studies in Mexico, we couldn't find such markers. Our children doesn't respond properly to the same doses. So that's, we can play them with doses, regimen doses, et cetera, et cetera. I don't know if I respond your question. Thank you.
Thank you. Yes.
Yeah. Thank you for a very nice presentation. I just wanted to ask you, because in many of our ethics committee meetings, we recommend having community advisory boards, or having members of the community or the indigenous population participate in the deliberations of the ethics committee in order to make the research more tailor-made to this. So have you sort of had an experience, or have you tried that, to have a community representative come in or have community advisory boards?
No.
Thank you.
The answer is, unfortunately, no. We should try to make participants of these ethics committees to indigenous population. I mean, unfortunately, it is hard to make these people get outside from their communities because it's far away. Sometimes 100 kilometers, it takes 12 hours or more to arrive. So it is hard for the people to move out. We should try to find some mechanisms in order to make participants of this kind of committees to the leaders of the communities in indigenous population, but I'm sorry, no, we don't perform it. Yep.
Thank you very much. Very interesting presentations. I was wondering, you did not, I think, mention about the cost of doing these tests and sustainability of doing this in the future, because if you find that you have identified risk factors, that I suppose would need to be, developed further, and then you need some support, financial support. So,
yep.
What's the next step?
All right. Yeah, it's a very, very good question. In fact, we have some grants, some support from the National Consejo Nacional de Ciencia y Tecnología from Mexico, National Council of Science and Technology in Mexico. So they provide us with some money in order to perform this kind of studies. Unfortunately, we have not found the proper media, the proper ways in order to translate the results we have to the health authorities. So yeah, it's a problem because sometimes they believe that these genetic markers are not useful. So they derive the money to some other kind of studies, more epidemiological, et cetera, et cetera, et cetera. So we don't have a mechanism, but we should try to search, to find. We receive proposals. Okay, sorry.
I've got the mic. Could I ask a very general question? Just to get an idea of the scale, roughly how many ethnic minority groups, however you define them, are there in the Americas?
Sorry, I lost you. I'm so sorry.
We've been talking about ethnic minority groups all morning. How many are there in the Americas, roughly?
Roughly, in America, in Latin America? Ooh. Kind of, maybe Dr. Sosa and Dr. Terán can respond much better that question. Marta, la población total, the total population, the total indigenous population in Latin America, Dr. Terán, roughly how how many people, how many population are?
I would guess that it should represent around 10-15% of the population in Latin America. It varies country by country, but it should be between...
That's not my question. My question
Sorry.
is how many groups are there? I mean, if we want to have pharmacogenetic profiles, then of course we need to discuss sample sizes and so on, but how many of these groups are there?
Okay. At least in Mexico, there is roughly 65 ethnic groups. However, most of them are very, very small groups and very tight groups inside the mountains of Mexico. So sometimes to perform this kind of studies in this kind of population is not representative of the indigenous, of the general indigenous population. I don't know for sure if Dr. Terán has another numbers.
Thank you. Yes, please.
I have a question for Dr. Terán. He mentioned that 20% of the population, the women in reproductive age, has the risk of having preeclampsia or eclampsia, and that there are genetic markers. This is a public health problem. So I wonder what has been the response of the Ecuadorian government, because this goes beyond the conventional research to address this problem. What has been done?
Yeah, I mean, it is a very huge problem. We have been fighting 20 years almost with that problem. Is a cumulative problem of several factors: teenager pregnancy, lack of prenatal care, undernutrition, poverty, etc. So what the government tried to do is try to identify very early preeclampsia risk factors. However, the problem is sustainability, because the tests currently available are very expensive for the system. So they try to provide those in the bigger cities where the problem is lower. The farther you are from the bigger cities, the higher is the prevalence. So we are trying to develop our own methods to detect early preeclampsia. The problem is that our successful is still limited by accessibility, because we need someone to sponsor our tests to be validated broadly and to determine if that works or not. We, for example, were unsuccessful to replicate what happened with the U.S. population. So, for example, aspirin, low doses of aspirin, are not working in Ecuadorian population. That is probably due to a genetic factor that women receiving low doses of aspirin still get preeclampsia in Ecuador. Yes.
Thank you. Any other questions? Yes, please.
Okay. I don't have actually a question, I have a comment, because it has been very interesting. One thing about this network is how much effort has been put on having phenotypes, not only genotypes, phenotypes, on having the characterization of the subjects. And that's an important thing, because we can never forget, we the geneticists, that pharmacogenetics, or any genetic marker, is a proxy. Yeah. It's always a proxy. And the proxies, they go out of fashion, especially when we use it for other things. So I was looking in the beginning of our darlings, the 2D6, the C8, 919, all that. And I came to mind of a phrase when I lived in the UK. I heard from someone, when your only tool is a hammer, everything looks like a nail. And I think that we're reaching a point here which these tools, and because the complaint was always the same, they don't predict, they don't predict, they don't predict. Yeah, so it's reaching a crisis now in this network where you found that it doesn't work. This needs a new technological step, obviously. I'm sure that the next step, if you can use next generation sequencing in order to have actually access to the full genes, will change completely this scenario, and things are getting cheaper. Otherwise, we'll be always having this kind of issues. It's really the proxy has to be optimized, and that's something that I think that with these 6,000 just gigantic banks that you have, you should think in those terms. Thank you.
Thank you. It's a very good comment, and actually what I would like to say is there is a lot of work, and extremely good work has been done, but how you translate it into the doable actions that would make a difference, because it's, you know, one is to monitor this, but then how you translate it to some meaningful actions. And I think this is increasingly a problem probably, and if somebody from the speakers has a good example where the scientific work has been translated into the actionable action, that will be good to hear if there is any examples of that. Anybody wants to comment on that? Okay, Nick, let's go further.
Yeah, G6PD genotyping has been used to profile risk for oxidative hemolysis following primaquine in different ethnic minority groups in Southeast Asia, and that's directed the radical cure of vivax malaria regimes.
So
I think that one was the problem, that we are calling too many things biomarkers, okay? And we should differentiate what is actually clinically actionable, and there are some examples like warfarin, clopidogrel, in pharmacogenetics. Some of them may work, we may improve how they work in Native American population. I wouldn't say that they don't work, okay? Even because they maybe don't work in specific populations that are isolated, but in the general population, there is a continuum between these populations. Even in Native American population, we have very good examples of isolated populations, but we also have a large amount of Native American population that some of them are much more mestizos, and in which it's better to use these tools that not to use them. Okay? And I think that the other problem is to differentiate which is actually an epidemiological association to what is actually clinically actionable. Okay? Because sometimes this lack of interest from government or from other stakeholders depends on the fact that we have so many false positive results. And we have so many false positive results because we don't replicate, we don't have enough sample size in our studies, and repeatedly having positive, false positives is actually a factor that sometimes make people less interested.
Okay, thank you. That is, yes, please, go ahead.
So I'm going to play devil's advocate. I want to know from your group that's done all this work, all of you, is it a good to have, or is it a must-have? Especially taking into consideration the challenges, and what came out loud and clear was the social determinants. So we look at equity, we look at access, we look at understanding, we look at language barriers, etc., etc., etc. So if we had to actually put this into, in a line, is it a must-have, or is it a good to have something that we need to aspire to? However, we've got to look at the equity and other issues first. What should be addressed? Because it's pointless us putting together guidance and guidelines when we're not going to be able to implement. And I'm talking from my experiences on the ground in Africa. So how would you advise your scientists, your governments, your funders going forward?
Ooh, it's a really, really hard question. Well, as I said in the presentation, it is hard to move, from the basic research to implement some more broad research, to implement some policies, some health policies. Because as Dr. Tarazona says, sometimes to replicate the results in some populations is hard to replicate in other. So this is in one side. The other side is how we can make an effort to join all these factors, such as the language barrier and all this stuff, in order to perform a kind of algorithm that will be useful for all populations in order to be more visible for the health authorities. I don't know, it's sorry.
Okay, last question, please.
Thanks. I agree with Ames on the different factors that need to be addressed before we get to genetic variability. Also, would like to say Eduardo said something very important, I think, clinical actionability. Because in the end, what it refers to is the patient that the physician has in front of him or her. And what do I need to do for this particular patient? And the awareness efforts on the genetic polymorphisms, for instance, I think are very important in that respect. If it is in a particular population 3% slow metabolizers or 10%, there's still the other 97 or 90% that are not slow metabolizers. And so I think the awareness helps in terms of understanding that there might be differences, and then also really tailoring the treatment to that particular patient. Because if you look at it from a population perspective, you never get really to what do I need to do for this particular patient who is in front of me. And in order to do that, I think we need to have everybody around the table, the geneticists, the physicians, actually policymakers as well, and governments in order to come to a consensus on this.
Thank you. It's true that not all that produces a nice PhD produces a difference in real medical practice. There are far more PhDs than real changes in medical practice, so we have to live with this knowledge. And with this very positive note, I'll conclude this session and we'll go to the lunch, and we'll continue the discussions during lunchtime, and of course after the lunch. I think I would like then to give an applause to all the terrific presenters with all the very good and very rich presentations. So